So good afternoon. After the big success of the 2020 educational course, the Cancer Research Group represented by Prof. Fadi Farahat and AMAAC, we are pleased to launch the 2021 ABC educational course. For the second year, the course will include a series of webinars talking different topics, modules over several sessions presented by excellent speakers. This year, translation to French is available to our colleagues in North Africa, giving more opportunities to them to attend and benefit from our courses. In the beginning, we will present a small quiz for the participants, so please do it. And after, when we're finishing, we will give another one, so just to know about the benefit that we got from this course. For the interpretation, as you see on the screen down, we have interpretation. Just click in it and then select the language do you want to hear our conferences. Now we are going for today. Our course will be unmet needs and challenges in first-line management of advanced non-small cell lung cancer. We are welcoming our first speaker, Dr. Danny Gaspard. Dr. Danny Gaspard, who is consultant of pulmonary and critical care medicine at Mount Lebanon Hospital in Lebanon. He will talk about diagnostic workup stage 3 non-small cell lung cancer patients, any update. After the second lecture, the panelists, Dr. Amani Mokrani from Tunisia and Dr. Layal Halabi from Lebanon and Dr. Pierre Youssef, also from Lebanon, will discuss the issues of the lectures and any comment from them. Please, Dr. Danny, the floor is yours.
Thank you. Thank you. I'm just going to share my screen. Okay. Okay, thank you very much for having me for this talk today, and thank you for all the organizers. Today I was asked to talk about the diagnostic workup of stage 3 non-small cell lung cancer and if there's any updates. So this is the quick outline of my talk. I will talk about what constitutes a stage 3 lung cancer, the diagnostic methods, and the invasive techniques that we can have to diagnose lung cancer. So the major goals of any evaluation that we can have is, one, you're going to try to find out what the clinical extent and the stage of the disease is. Can you diagnose it off the bat, or do you need more evaluation? The optimal target for your first biopsy. The biopsy has to show us the specific histologic types. You have to factor in the comorbidities, the complication, any paraneoplastic syndrome, and any patient preferences. When we talk about lung cancer staging, we talk about the 8th edition of the TNM classification. And I just wanted to show you how important it is to correctly stage your mediastinum, your lymph nodes. So the T stage you will get with your CT scan and or PET scan, the M stage as well. Sometimes you need a biopsy to see what your M stage is, but most of the time it's obvious either on your CAT scan or on your PET scan. But the lymph nodes, it's very important to stage them. For example, if you have a T2 lesion with an N0 lymph node, we're talking about 1B or 2A disease, and the goals of your treatment will be a curative surgery. Whilst if you have an N3 lymph node with a T2 mass, you have a 3B non-curable disease where you're aiming for palliative chemotherapy or immunotherapy. So this is a picture of the lymph nodes as you see them. So this is stage 1, 2, 4, 7. So anything that's single digit is mediastinal. Anything that is double digit is hilar. So this is, for example, right hilar lymph nodes, left hilar lymph nodes, and the mediastinal lymph nodes. So when you do your first evaluation, you get a CAT scan, the patient is having symptoms, or you do your initial CT, and you're gonna have 3 categories of patients. You have the obvious patient with metastatic disease, the patient who has a radiologic stage 1, and I will discuss that very briefly, or the patient who has possible N2 or N3 lung involvement. So radiologic stage 1 is very well defined in the guidelines. When we talk about guidelines, we have the ACCP, the American College of Chest Physician Guidelines from 2013. These are the biggest guidelines. They don't have any updates. There may be updates in 1 or 2 years. And you have the European Society of Medical Oncology from 2018. They discuss mostly these things. But basically, they say that when you talk about radiologic stage 1 disease, your mass shouldn't be too big. It's less than 3 centimeters, and it has to be peripheral. When it's central, there may be involvement of your lymph nodes. So if you have a peripheral mass with normal lymph nodes and no uptake on PET scan on your lymph nodes, then you consider it at stage 1 and you go directly to surgery, you remove it, you send it for frozen section. If that's considered cancer, then you have your total lobectomy and lymph node dissection. When you have obvious stage 4, you go directly to the easiest site where you can biopsy, so you can get tissue and do your immunomarkers and things like that. But when you have possible stage 2 or stage 3, so possible N2 or N3 lymph node involvement, then you either have a lymph nodes that are large, a PET positive lymph nodes on PET scan, or central tumors, even if they're smaller, or if the lymph nodes look normal, there still is a possibility of N2 or N3 lymph node involvement, and you still need to evaluate your lymph nodes. What are our diagnostic modalities? So the most basic one, the one that we're going to use all the time, is your CT scan. It's done for almost every patient, and you're going to do it with IV contrast if you can. The CT scan will give you the T stage. Sometimes it will give you the M stage, the stage 4. But the problem with using the CT scan as the sole staging modality is it does not have a good sensitivity. As you can see, it's 50% sensitivity. Even the specificity is about 80%. So the CT scan will be done to all these patients, but it's not the first. It cannot be used as the only test to stage your cancer. How about PET scan and PET CT scan? Can we use that as the only staging modality? So it is more accurate than the CT scan. It will show us places that look normal on the CT but will light up on the PET. So it will upstage the cancer commonly. So it will save us from doing a surgery for a patient who already has a metastatic disease. The problem with PET scan is, 1, there's no consensus of its value as a staging tool. 2, the studies have shown that it helps with your accuracy, with your diagnostic accuracy, but it doesn't improve mortality. And 3, that there is no strictly defined criteria as to what constitutes a positive PET result. So when your nuclear radiologist reads a PET scan, he will say you have an SUV of 2 or 2.2 or 2.5. Who knows what 2.2 versus 2.5 means and what the true cutoff is? Sometimes you'll see something that looks lukewarm and you're not sure if it's inflammatory, and then you biopsy it and it's positive, and sometimes it's the other way around. So do the guidelines recommend doing a PET scan? Actually, they do. They say we recommend doing a PET scan to evaluate for metastasis in patients with suspicion of lung cancer, of non-small cell lung cancer. Now, can it be used alone for staging without going and doing a biopsy, doing an EBUS or a mediastinoscopy? So the sensitivity of the PET scan is 80%. So you're still going to miss about 20%, which is a high number when you're talking about cancer. Plus, it's not fully specific. It's 88%. So about 10% of them will be, you're going to miss 10 to 12% of them. So that's why it's dangerous to just rely on the PET scan for staging. And that's why the guidelines recommend that if you have a lymph node that's enlarged with or without PET scan uptake, then you should go do a biopsy. And if you have a lymph node with PET scan activity, even if it looks normal on the CT, you should still go and do biopsy. And all the guidelines agree to this. You don't rely on the PET scan by itself as a staging modality. A quick word about brain MRIs. So brain MRIs, they differ a little bit between different guidelines. For example, the NCCN says everybody except stage 1A. The PTS guidelines say for when you're considering curative therapy, and the ACCP guidelines say stage 3, stage 4, or symptomatic patients, any neurologic symptoms. Okay, moving on to the last part of the talk, and that's the invasive staging of the mediastinum. So you're trying to go and biopsy these lymph nodes, and basically you have 3 methods. The first one is EBUS, the second one is mediastinoscopy, and the third one is VATS or thoracotomy. So off the bat, I will tell you, we very rarely will have to use VATS or thoracotomy to stage a mediastinum or to stage a lung cancer. That's a very aggressive approach, and we have less aggressive approaches now, these 2 other approaches. So I will not talk much about it. This is for the very odd case where you have something you cannot get to with the other 2 modalities. So what is EBUS? So EBUS stands for endobronchial ultrasound. That's basically a bronchoscope with an ultrasound at the tip of it. So when you're in the airway, your lymph node is right outside the airway and you cannot see it. But when we have this special bronchoscope that has this ultrasound at the tip of it. So when you lay it against the wall of the bronchus, you're gonna see the lymph node. It looks like this. It's salt and pepper. If it looks all black, it's a vessel. If it looks like this is soft tissue. And then you stick your needle out and the needle goes into the lymph node and you actually see the needle inside the lymph node. And as you can see, look, all of these lymph node stations are close to the airways, so you can get to all of them. You can even get to 8 and 9 if you go through the esophagus. The lymph node stations that you cannot get to with EBUS are 5 and 6 because you have the pulmonary artery and the aorta in your way. So your needle can't get through those to get into the lymph nodes. EBUS, as you can see, has a sensitivity that's very good. It's 89–90%, and the specificity is very high. And I will argue that, so combined EBUS-EUS means if you go also through the esophagus and you look at the other lymph node stations that we talked about. And I will argue that the most important thing in these tests are the negative predictive value. Basically, if I go and look at the lymph node and biopsy it, and my biopsy comes back negative, how much can I trust that result? And how much can I say, okay, this lymph node is negative, I can properly stage my cancer, and then I can move to therapy. And the negative predictive value is 91% and even 96% with the combined EBUS and EUS. So what is mediastinoscopy? Mediastinoscopy is a minimally invasive technique done by cardiothoracic surgeons, where they make an incision here above the sternal notch. It's a small incision, it's a 1 centimeter incision, and you go in with a mediastinoscope. You had the regular mediastinoscope where they had to look and get in there. Now we have the video mediastinoscope, which are much better performing. You can go in and you can take chunks and pieces and even entire lymph nodes with the equipment that they have. The sensitivity is also around 90% and the negative predictive value is more than 90%. And these are even older studies, so they're even better. So comparing the 2 techniques. So the pros of EBUS is it's a bronchoscopic technique. It's minimally invasive. It's a same-day procedure. They just go in, stay there for a couple of hours, and then go home. Minimal anesthesia requirements. What is gone against EBUS is it's a needle technique. We have big needles, but it still is a needle technique. So sometimes when you need to see the entire lymph node, like for example, when you're suspecting lymphoma or things like that, so we can only get a needle biopsy, not a core biopsy. As for mediastinoscopy is considered the gold standard because you can get, as we said, chunks and pieces of the lymph node. You can get the entire lymph node. So in pathology, obviously, the more tissue you can get, the better the reading for the pathologist. The problem with mediastinoscopy is it can assess the mediastinal stations, but cannot get to all the hilar lymph node stations because they're, as you can see, it's just on the hilum, so they cannot get to them with mediastinoscopy. And you might need more anesthesia because it's a surgical intervention. Sometimes, most of the time, the patient is admitted for 24 hours and discharged home the next day. So as is everything in medicine, when you talk about 2 techniques like this, they don't mutually exclude each other. The best approach is to actually combine them. So this is very quickly a randomized controlled trial of 241 patients. And they tried doing just EBUS and EUS for some of them, just surgical, just mediastinoscopy for some of them, and then a combined EBUS EUS followed by surgical staging, meaning if you have an EBUS EUS, if it's positive, you proceed to treatment. If it's negative and there's high likelihood, then you go confirm your results with mediastinoscopy. And guess which approach was the best? Obviously the third one, and you had the sensitivity of 94%. So what do the guidelines recommend? The guidelines recommend exactly that. So doing your first intervention should be a needle technique, an EBUS or an EBUS EUS, and that's a grade 1B recommendation. The ESMO guidelines have exactly the same recommendation. So grade 1A endosonography is recommended over surgical staging, but if it does not reveal nodal involvement and a suspicion of high clinical suspicion, then you should go to mediastinoscopy, and that's also a 1A recommendation. Okay, so I will end with this. Basically, that's what they tell you to do. If your lymph nodes are negative, your mass, this is from the ESMO guidelines again. If your mass is peripheral and less than 3 centimeters, you proceed directly to surgical resection. If your lymph nodes are negative, but the tumor is more than 3 centimeters or it is central, then you do your EBUS. And if that's negative, that's low suspicion. So when your lymph nodes are negative, you can proceed to surgery. If your lymph nodes look positive on PET scan or on CT scan, they look abnormal in any way, that's what we said we could do EBUS and EUS. If that's positive, you proceed to surgery or to multimodality treatment. And if that's negative, then you confirm your results with mediastinoscopy. And I will end there, and thank you very much for listening.
Thank you, Dr. Dani, for the excellent lecture and keeping the time very well. So our next speaker, I don't know if Dr. Fadi Karak is with us.
Yes, good afternoon.
Yeah, good afternoon, Dr. Fadi. So our next speaker, questions will keep it for the panelists to discuss it with the participants. So Dr. Fadi Karak, who is hemato-oncologist at Hotel Dieu de France University Hospital in Lebanon. Dr. Fadi, he will talk about the immuno-oncology, a game changer in multimodal management, locally advanced non-small cell lung cancer. Please, Dr. Fadi, the floor is yours.
Good evening. Thank you, Fadi, and thank you, Dr. Khatib, for the invitation. So first, I'm not sure if you're seeing my full screen because sometimes I have problem with this. Are you seeing?
Share the screen, please.
I'm sharing it right now.
Just we see your first slide.
So I have the same problem. I believe it's in my computer. So maybe SciencePRO can help me, and if they can share from their side, it will be easier. كل مرة بجرب أعمل شيرينج بحط ما بقدر أحطها فول سكرين.
Fadi, we were seeing it as full screen, honestly.
Yes, doctor, it worked. Can you please try again once?
يلا. بس تكون مبينة فول سكرين لأنه مرات ما بتبين.
Okay.
هلا حطيتها فول سكرين. Is it okay?
Yes, it's working.
Okay, yeah. Perfect.
It's
so
okay.
My talk is about immuno-oncology, a game changer in multimodal management of locally advanced non-small cell lung cancer. And Dr. Farhad asked me clearly just to not have a simple symposium, but just to go through an educational session about how we manage the stage 3B and C non-small cell lung cancer. So just a small reminder in one slide, what are stage 3B in C and C? So these are typically patients with N3 disease. So these patients have contralateral mediastinal lymph nodes, or patients who have N2 disease, which means patients have ipsilateral mediastinal lymph nodes with either big tumor more than 7 centimeters, or with invasion of mediastinal organs, or even two ipsilateral two tumor nodules in different ipsilateral lobe. So we're talking, during this talk, we will be talking about the management of this stage of this disease. Fortunately, in this stage of disease, many questions were solved. not like for stage 3A. So for stage 3B and C, we have many questions that were answered during the past years. Like, for example, should we use B-modality treatment like chemotherapy and radiation, or monomodality like chemotherapy or radiation alone? Should we use concurrent treatment of chemoradiation or sequential? Should we do induction chemotherapy before concurrent treatment? Should we do consolidation treatment after concurrent chemoradiation or not? Which chemotherapy regimen should we use? What is the dose of radiation that should be used? And what is the role of immunotherapy? So I will go quickly about the key meta-analysis and studies that got us to our standard of care today. So you all know that there is no role for surgery for stage 3B and C in the non-small cell lung cancer. So the standard of care is just to give chemotherapy and radiation, but what is the best way for giving it? So we have the first question. We have three main studies and meta-analysis showing that sequential chemoradiation or concurrent chemoradiation are each superior to radiation alone. And we have also another Cochrane database analysis and Opera meta-analysis that proved that concurrent chemoradiation is superior to sequential chemo and radiotherapy. And here is the first Cochrane database that showed clearly that when you do concurrent chemoradiation, it's much better than doing radiation therapy alone, with a hazard ratio of 0.71. So that's 31% reduction in the risk of death whenever we do the combination treatment rather than one modality. And here is another meta-analysis showing that whenever we do concurrent chemoradiotherapy, it's better than doing sequential chemotherapy followed by radiation, with 10% less risk of death at 2 years. So that's another meta-analysis of Opera. That's very famous one because it was very well done and the studies were very well chosen. That again, they proved in stage 3B and C non-small cell lung cancer, giving concurrent chemoradiation increase the 3 and 4 and 5 year overall survival by around 5%. So since this meta-analysis, the standard of care everywhere in the world for stage 3B and C became concurrent chemoradiation when we give chemotherapy and radiotherapy all together. Then we had many questions. One of them, should we do more consolidation treatment after concurrent chemoradiation? منين جاي الفكرة؟ الفكرة جاي إنه إذا أنا عندي stage 1B أو 2, patients will get 4 cycles of platinum-based chemotherapy. If you have stage 4 disease, patients will get at least 4 cycles of platinum-based chemotherapy. Why in stage 3, we are giving our patients just 2 cycles of platinum-based chemotherapy with radiation? So the idea was we should give more chemotherapy like we're doing with stage 1B, 2, and 4. So we have many trials. Unfortunately, all of them were negative. The majority of trials just gave consolidation, docetaxel, and cisplatin for 2 cycles after the concurrent chemoradiation. But as you can see from this meta-analysis, there is no added value of adding 2 more cycles of platinum-based treatment. And on the top, there is much higher risk of giving radiation-induced pneumonitis. So based on these trials and this meta-analysis, nobody was giving more consolidation treatment after concurrent chemoradiation. So the standard was just 2 cycles of platinum-based chemotherapy with radiation. So if you look at the ASCO and ASTRO recommendation guidelines, they state clearly that there is no role of routine use of consolidation chemotherapy after concurrent chemoradiation. They said it remained an option for patients who did not receive the full dose of the 2 cycles of chemotherapy, mainly because of side effects and pneumonitis. If we want to move to induction chemotherapy is an idea of oncologists. And I believe also that's not true. Sometimes we have a false idea that we want to prove. So if you have big bulk of tumor, all the time the oncologist try to tell the radiation, let me give the patient 2 cycles of chemotherapy, so the tumor will shrink, and then when we will give concurrent chemoradiation, the share of radiation will be smaller. As you can see, there are many trials. Some of them are of the CLGB. 2 trials were from the CLGB, but all these trials were negative. There is no role for induction chemotherapy for bulky tumor. We'd have just to go with concurrent chemoradiation, especially that we have now a very good technique for radiation to avoid toxicities. Which chemotherapy regimen should we choose? So we have 3 regimens that we can use with radiation. The standard of care for years was EP 50/50. It's very complicated regimen. All oncologists hate giving EP 50/50. It's a combination of etoposide and cisplatin for 2 cycles during the radiation. Once I was in a meeting in the United States, there were like 1,000 oncologists, and they were voting for what they are giving their patients with concurrent chemoradiation. 85% of them answered weekly carbotaxol. So the majority of physicians in the private practice in the US, they use weekly carbotaxol. If you go to university hospitals, they stick for the EP, they give EP 50/50. And we have an option, of course, for adenocarcinoma patients to give 3 cycles of Alimta and cisplatin. And I will show you two slides in 2 slides these studies. So that's the comparison between EP 50/50 and carbotaxol. You can see that maybe when you give cisplatin, it's a little bit better than carbotaxol, but this difference was not significant. And there is more toxicities, mainly radiation-induced pneumonitis. So that's why the majority of private centers in US give weekly carbotaxol. And that's the PROCLAIM study comparing Alimta cisplatin versus EP 50/50 in adenocarcinoma patients. And you can see that these regimens are the same. So practically in Lebanon, we give Alimta cisplatin with radiation for adenocarcinoma, and for squamous histologies. If the patient is frail, I usually give weekly carbotaxol. If the patient is fit, I go for EP 50/50. We try to integrate more treatment into this after chemoradiation, like we tried to add cetuximab or Avastin or thalidomide. All of these trials were negative, or they're closed very early. What is the dose of radiation that we should use? Again, in 2008, there were a tendency toward increasing the dose of radiation to 72 gray or more. But then there was this interesting study that compared the 2 doses of radiation, 60 versus 74. And as you can see, 60 gray is much better than 74 for the survival of our patients because of the toxicity with the 74 gray. So now the majority of center in Lebanon just give 60 to 62 gray. That's the standard of gray. So you have to go above 60, less than 64. So this was the standard of care of concurrent chemoradiation alone, with no consolidation, with no induction, with no added treatment for the last 30 years. And recently we have the incorporation of immunotherapy for the last 3 years. So the idea that radiation just induces tumor cell death, and then whenever we have tumor cell death, we have more antigen released into the circulation, we have more PD-L1 upregulation, and then we can give an immunotherapy, which is the Imfinzi, the durvalumab, just that can come and block this PD-L1 and causing cell death. This is how Imfinzi works. So it blocks the PD-L1 on the tumor cells and in the immune cells. This drug is the first and only approved immunotherapy to improve OS and PFS in stage 3 non-small cell lung cancer, followed with concurrent chemoradiation in unresectable patients. This approval was based on the Pacific trial. This is a very straightforward phase 3 trial where patients who received concurrent chemoradiation, they received at least 60 gray of radiation, and they received at least 2 cycles of platinum-based chemotherapy. And then they were randomized during the first months. Within 42 days after the end of concurrent chemoradiation. They were randomized 2-to-1 fashion, whether they receive Imfinzi 10 milligram per kilogram once every 2 weeks for a year, or nothing every 2 weeks for a year. The primary endpoint of the trial was a co-primary, the overall survival and the progression-free survival. If you look at the patient characteristic, you can see that half of the patient have stage 3A, half of them has stage 3B, half of them have squamous histology, half of them have non-squamous histology. 24% of patients has PD-L1 more than 25%, and the third has PD-L1 less than 25%. Here is the primary endpoint. You can see this striking slide showing that there is 32% reduction in the risk of death whenever you add durvalumab after the end of concurrent chemoradiation. The median OS for the placebo was 28 months compared to not reached with durvalumab. If you want to extend the follow-up and take a look at the 3-year overall survival, you can see that this difference is maintained at 3 years with 57% overall survival at 3 years compared to 43% with placebo. Here is the second co-primary endpoint, which is the progression-free survival. This is really an unprecedented increase in PFS, around a year increase in PFS whenever we add durvalumab versus placebo. And we can see that almost half of the patients are alive after, are disease-free after 1 year. These are pre-specified subgroups. You can see that all the subgroups of patients benefit from the durvalumab. I want to focus on 2 subgroups. These are patients who have partial response or stable disease at the end of concurrent chemoradiation. So it doesn't matter if you have partial response or stable disease, durvalumab will help the patient to increase, hopefully, his overall survival. And on the top, it doesn't matter if you have EGFR mutation positive or negative. So it's not like in stage 4 when we deny immunotherapy for patients with EGFR mutation. So in stage 3B, I encourage the patient not to do EGFR mutation because it's of no value at this stage. One very important point, so for the oncologists who are following patients with concurrent chemoradiation, we usually tell the patient at the end of concurrent chemoradiation, just stop. At the end of chemoradiation, we tell the patient, go home and repeat your scanner in 6 weeks, and I will see you in 6 to 8 weeks, just waiting for the pneumonitis to get better and to be able to better see the tumor, to see the response. So this we should not do whenever we want to give durvalumab. If you look at this pre-specified endpoint, so patients who started the Imfinzi during the first 14 days after the end of radiation, concurrent chemoradiation, do much better than when they start between the 2 and 4th week. So in the trial, so the main objective, if you feel that the patient has a stable disease and the patient does not have progressive disease elsewhere in the body, so you can immediately start the durvalumab. So what we typically are doing now, patients finish his concurrent chemoradiation, I give the patient a CT scanner to do during the 1st week, and irrespective if he's feeling better, even if I see a lot of pneumonitis, or I have the impression that he might have a progressive disease on the lung mass, I start immediately with durvalumab and repeat the scanner in around 2 months, just to be able to put my patient with the best hope of receiving the durvalumab during the first 14 days. So in the trial, it was based on the impression of patients getting better without signs of distant metastasis. The quality of life of patients, of course, it's about the same. If for physicians who gave Imfinzi, they know that this drug doesn't have a lot of side effects, and quality of life stays the same compared to placebo. And also for physicians who gave durvalumab, I believe all of us have seen that this drug has much less adverse event than other immunotherapeutic drugs that we use in stage 4 disease. And this was very well illustrated into this trial when you look at the grade 3-4 adverse event in placebo and Imfinzi arm. You can see that they are almost similar. And even when you look at the typical immune-related adverse event, they are much lesser with this drug when you compare to other trials with Keytruda or nivolumab, for example. Pneumonitis 1.7%, hypothyroidism 0.2%, rash 0.4%. Really, it seems that anti-PD-L1 are a little bit safer than anti-PD-1. So the drug is given at 10 milligram per kilogram in a 1 hour infusion once every 2 weeks for a total of a year, so 24 injections. That's my last slide. This is the standard of care for the management of patients with stage 3B and C, concurrent chemoradiation, 60 gray of radiation with at least 2 cycles of chemotherapy based on platinum, and followed by durvalumab starting during the first 2 weeks after the end of concurrent chemoradiation for 1 year. And I want to thank you so much.
Thank you, Dr. Fadi, for the comprehensive lecture. Really, it's excellent lecture. Now we have our panelists, Dr. Amina and Dr. Layal and Dr. Pierre. So the floor is yours just to take the questions that we have from the participants and to discuss anything that you want.
Hello, everyone. I'm Dr. Halabe. Just to start, I want to thank Dr. Gaspar and Dr. Karak for their excellent presentations. And I think that we really need, whenever we speak about stage 3 non-small cell lung cancer, to mention the importance of the multidisciplinary meetings. It's very important to really appropriately stage these patients and to choose the best treatment from the beginning. And I think Dr. Yusuf has been involved in really many meetings. So I'll start with the questions. So do you think we can diagnose lung cancer with cytology from pleural fluid? Is it enough in diagnosis, or do you think we must have tissue for a full diagnosis, providing we should have EGFR, PD-L1, and other biomarkers? So Dr. Karak may answer this question.
Yeah, so the answer is on the hand of the pathologist. So if the pathologist is able to give me the full answer about the type of cancer, EGFR, ALK, ROS1, and PD-L1 on cytology, why should I do a pathology? So sometimes they do cell block, and on the cell block they can do all these extractions, and I don't care as long as I have the answers. Otherwise, I should definitely go and do a biopsy. So I believe in lung cancer now, it's like breast cancer. We cannot treat a patient without having ER-PR. We don't tell the patient, oh, I don't have material to do ER-PR, so I will treat you like I don't have the result. No, in lung cancer, it is the same. I cannot treat any stage 4 lung cancer without having at least EGFR, ALK, ROS1, and PD-L1. These are very essential to the management, and I should repeat the biopsy before initiating any treatment.
Yes, sure.
Layal, the days of just getting a little bit of tissue are long gone. Like, it used to be very simple. Right now, I fight with my interventional radiologists when they want to do cytology. I tell them I need a core biopsy. When I do a biopsy in my bronchoscopies, I do multiple bronchoscopy. Basically, we need a lot of tissue. It's not common for us to get the result just from pleural fluid. I can tell you from draining a lot of them, you just need a lot of cells to do all the biomarkers that Fadi just mentioned. I mean,
yes, sure.
you can have the occasional patient, but commonly it's not enough.
Especially in metastatic disease also, it's much more important. So I will take another question, and then I will leave the micro for the other panelists. So it's for you, Dr. Gaspar. Is there a risk of perforation in EBUS biopsy?
So the risk of perforation is very small. So typically what we do is you see the airway and then you put a needle through it. So because it's not a forceps or a big tool, the risk of perforation is very, very small. Overall, the risk with EBUS is very small. It's less than, it's about 1 to 2%. Most commonly, it's hemorrhage or pneumothorax. The risk of perforation is in the order of 0.0 something. So very, very uncommon. Most commonly, the complications you're going to get are either from the anesthesia you're going to give. So we give conscious sedation, but if they have a reaction to the medication, or hemorrhage or pneumothorax most commonly.
Okay, so I'm going to ask Dr. Youssef a question. What about the complications of mediastinoscopy? Dr. Youssef, you need to unmute yourself.
Yes, it's okay now, yes?
Yes, now it's okay.
Good evening, Layal. I can't say in all the years when I am doing mediastinoscopy, perhaps 2 years ago, I have done a severe complication in a patient with a large mediastinal mass. It came at the end, it is a Hodgkin lymphoma. The reason for that, there were neovessels. You can't see them. And we used to give him 4 units of blood and to intubate him for 2 days and then to come back and to review the mediastinum. This is the only severe complications in more than 3,000 mediastinoscopy I have ever done in my life.
Okay.
Have one participant raising hand if you would like to give him the access to ask. SciencePRO, please. He is disconnected, so please continue.
Bonsoir, bonsoir tout le monde.
Bonsoir.
Bonsoir, Amina.
Bonsoir. Est-ce que je peux parler en français? Ça vous dérange pas? C'est plus facile pour moi.
Bien sûr, on pourra faire la translation, la
Merci.
Traduction, oui.
traduction.
Très bien. Moi, je suis oncologue médicale à Tunis, à l'Institut Salah Hazaï, donc le centre anticancéreux. Je suis ravie d'être là parmi vous. Je voudrais poser une question à Dr Fedi. Nous, en Tunisie, on utilise beaucoup le navelbine platine en concomitant, qui est moins cher d'abord, plus facile à manier que le paclitaxel carbo hebdomadaire. Pour le Pemetrexed, on n'a pas une facilité d'accès à cette drogue. Donc, j'ai vu que chez vous, le navelbine platine en concomitant n'existe pas, entre guillemets, bien que dans les recommandations, aussi bien européennes ou américaines, c'est un schéma qui est recommandé.
Excellente question, vraiment, c'est une excellente question. Donc, quand je suis revenu au Liban, j'ai utilisé un peu le navelbine cisplatine. Malheureusement, les études sur navelbine cisplatine avec la radiothérapie, c'est des petites phases 2. Soit des petites études rétrospectives, soit des petites phases 2. Il n'y a pas comme avec, par exemple, l'étude que je vous ai montrée avec alimta cisplatine ou le protocole de étoposite cisplatine. Donc, pourquoi pas? Moi, je l'ai utilisé. Aux États-Unis, jamais ils utilisent ce protocole. Mais on peut l'utiliser, par exemple, pour les épidermoïdes, parce que vraiment, je pense, pour les adénocarcinomes, la meilleure combinaison, c'est alimta cisplatine. Ça se combine très bien avec la radiothérapie. Et comme toxicité, vraiment, on est tous habitués à ce type de protocole, si vous avez l'accès, bien sûr.
Oui, malheureusement.
Sinon, la navelbine cisplatine, c'est pas mal. L'evidence base sur ce régime est vraiment petite sur des phases 2 ou rétrospectives.
D'accord. Autre chose, Dr. Fay dit, pour l'essai pacifique, le bénéfice est plus important pour les PDL1 positifs, alors que l'approbation de la FDA, c'est pour tous les patients. Donc, le sous-groupe PDL1 négatif, le hazard ratio n'est pas aussi bon que ça.
Vous avez complètement raison. Donc, le groupe qui bénéficie le plus, c'est le groupe qui est PDL1 positif, 100%. Donc, maintenant, dans notre crise économique au Liban, moi, je suis en train de donner le durvalumab seulement pour les patients PDL1 positifs parce que le bénéfice, il est vraiment minime pour les PDL1 négatifs. Ces patients, ils représentent presque 25% des patients. Il y a un bénéfice, mais il est minime.
Oui. Autre chose, Dr. Fay dit, pour les patients qui progressent au durvalumab, est-ce que dans l'essai pacifique, on a une idée sur, entre guillemets, la ligne ultérieure qu'ils ont pris comme traitement? Qu'est-ce qu'ils ont eu comme traitement?
Donc, si vous demandez s'ils ont reçu de l'immunothérapie après ou,
Oui.
ou de la chimio. Non,
Non,
on n'a pas cette information.
D'accord.
On n'a pas cette information de qu'est-ce qu'ils ont reçu après.
D'accord. Merci.
Merci à vous, Amina.
Oui, avec plaisir.
Fadi?
Would you like to continue with some questions or keep it?
I have one question for Fadi Karak.
Yeah, تفضل.
I'm ready.
Fadi, about T3, T4, and 2 disease. In the new classification, it is a 3B disease. It is true, yes? Fadi, do you hear me?
Yeah, I'm hearing you بس بقطش شوي ما سمعتش السؤال sorry.
أنا عم بقول بال T3, T4, and 2, it is now in the new classification, it is a 3B disease.
Okay.
If you have the combination of T3 or T4, and you have a single paratracheal lymph node, which is less than 3 centimeters.
I agree with you. So I can get your question. So your question, is there a role for surgery for a minority of patients who have not multistational lymph node, mediastinal lymph node involvement, even with T3 disease? So T3 and 2, or for example, 2 nodes in the same lobe and
Exactly.
1 ipsilateral. So these patients, of course, are surgical if the patient is fit. So that's why stage 3 has to be multidisciplinary team discussed. So such patients should might benefit from surgery. Yes, of course.
Yes, agree. Danny, also a question of our communication always together with a lot of patients between us, you and me. We have some trouble with the EBUS, you know that.
Yes.
Even in the hand of an expert as you and an expert in the pathology where you are working, even so, we have a lot of negative answers. And this is for me always a question. If we have to believe only in the EBUS or to send this patient in this specific question for either mediastinoscopy or even thoracoscopy to define the staging and to decide if they will perhaps benefit from surgery or not. Do you agree with me?
I completely agree. I completely agree. So this is why, like, you know, it's been mentioned that it's so important to do the multidisciplinary discussion. So every time before and after I do my EBUS, and I do my biopsies, and after I get the results, I call the oncologist and I call you, because these are some cases that we need to discuss together. We should, when we have an EBUS, so the EBUS, the sensitivity is about 90, it says 90, 91, 95. So you can miss, let's say, up to 10%, where let's say your needle goes into a different area of the lymph node and you don't get cytology. They're hard lymph nodes and you get a negative EBUS, but you still have suspicion for malignancy. then you should go and do mediastinoscopy. So mediastinoscopy is still considered the gold standard. So because you can get the chunk, the entire lymph node, and you don't miss that way. So we need to do an EBUS, and if the EBUS is negative, we need to, and we have a high suspicion of nodal involvement, then we need to confirm with a mediastinoscopy. I agree.
Dear panelist, there is
Dr.
some
Hisham
question.
is raising hand. Dr. Hisham is raising hand. Can we hear him?
The question is not clear, Dr. Hisham.
Yeah, the question is not clear at all.
That's our youngest attendee for the day.
So please, if you couldn't unmute him, and if you, Dr. Halabi, like to take another 2 questions and then to follow with the lectures.
Okay. So some of the questions have been answered already. I think liquid biopsy for the mutational analysis mostly can spare the patient the rebiopsy. Do you agree?
I completely agree. So when we first do the drainage, so let's say the patient presents with a large pleural effusion. The first thing we're going to do is drain that fluid and send it to our pathologist. As soon as we get the answer, the pathologist will get a phone call from me or from the oncologist saying, do you have enough cells for immunostaining? So do you have enough cells to do the EGFR, ALK, PD-L1, immunohistochemistry, all of these? And if the oncologist answer is yes, then obviously you don't do anything else, because this is a stage 4 if you have a positive pleural fluid. So the only thing that you need is the type of cancer and the immunostaining and the markers. So, but if the answer is no, then you have to find another way to get more tissue to have all these tests.
Yes, I'm not sure if بعتقد السؤال هو عن genomic studies.
Okay.
You opened a high, yes.
So I believe the question is about the liquid biopsy, that just drawing blood and sending NGS on this blood, trying to find mutation.
Okay.
And the answer is that it's not yet standard of care. So we have many trials showing comparison between NGS on biopsies and on liquid. It's not yet standard of care. And I believe during this educational session, we have to stay standard of care. Standard of care is doing tissue biopsy and analysis. In the future, maybe.
In other words, if you allow me, we try always to do tissue biopsy. When we cannot succeed, we go for liquid biopsy, specifically in lung cancer, because it's not always easy to take a biopsy. And in tissue biopsy, you can get more than DNA analysis. You have RNA and IHC, which is not the case in some others. That's why we still rely on tissue biopsy. And also we have to know that in some studies, for example, in other diseases, there was some positivity in tissue and negativity in liquid and vice versa. So it's really a hot topic, not fully resolved till now. But as Dr. Karak said, standard of care, now it's tissue biopsy. Thank you.
So if you want, we can move to the next presentation, and then we can go back to the questions in order to stay on time.
Thank you. Yes, thank you, Dr. Halabi. And we'll be back, all of us, to discuss about the other 3 lectures that we have. So now it's my pleasure to present Dr. Fadi Farahat. As you all know, he is the president of the CRG, the Cancer Research Group, CG, and head of the Hemato-Oncology Department at Hammoud Hospital, University Medical Center. Dr. Farahat, he will talk about the redefining survival expectations in frontline metastatic non-small cell lung cancer patients. Please, Dr. Fadi, the floor is yours.
Thank you very much, dear friends and colleagues. So talking about immunotherapy today, I will say that we know very well that it has a strong efficacy, manageable safety. It works in a variety of tumor types. It has a really good response rate. And the application in lung cancer, specifically non-small cell, gave us improvement in response rate, PFS, and OS. And that's why we started using this treatment in our practice. Here I have some cases. The first is a patient of a 55-year-old diagnosed in 2016 with a left lung adenocarcinoma T2 and T2M1. She had no driver mutation and PD-L1 was high. We did it later on, but I'm putting it now. And she started by receiving the cisplatinum Alimta plus maintenance. And she had a good partial response. After that, we went to the irradiation of the mediastinum. I don't recall the reason, but she was irradiated. And then after a few months later, about 12 months, 13 months, she progressed. So we started pembrolizumab monotherapy. And she went in response, good response, partial response, 20 months after the beginning. And, a few months after, and then in 20 months from the treatment, she became complete response. Here it's important, just I'm mentioning this case because we got partial response, and more than 1 year later, she was switched in complete response. And till this day, which it's about 46 months, she's in complete remission for a M1 disease. And the second case, it's a 69-year-old in July 2018, adenocarcinoma stage 4, no driver mutation, high PD-L1, who refused any idea of chemotherapy or chemo. So we went for also pembro. I will talk about pembro mainly. I will keep for the next session to talk about the other immuno. So I will emphasize on pembro in this presentation. And the patient is still in partial response with excellent PS 35 months after. So very nice cases. And again, a third case, stage 4, no driver mutation, high PD-L1, and still 27 months with mono pembro in 27 months, more than 2 years, in partial response. When I say in partial response, these patients are really in a PS of 0. So it's not only about PR, it's about excellent quality of life, 0 symptom. So yes, we have a lot of interest when you see such cases in second line, more than almost 4 years, 3 years, and more than 2 years response, objective response with PS 0. So yes, we know and we are using that because of the approval of this drug. But look, when you try to have, I'm sorry about the quality of the slide, but when you try to see the NCCN guidelines, immunotherapy is invading the NCCN guidelines. So it's everywhere. Immunotherapy for the PD-L1 more than 50%, you can get pembro, plus minus chemotherapy, you can get atezo, you can get also semiplimab, and other recommended options are also category A. And in less than 50%, also again, pembro with atezo and nivo EP. So as you can see, really it's everywhere. Now this make for us some difficulties because we have some challenges when using the treatment in M1 non-oncogenic driven non-small cell lung cancer. So as you saw in this presentation, which immunotherapy I have to use if I want to use immunotherapy? Should I use anti-PD-1, PD-L1, CTLA-4, combination chemo, immuno, or immuno alone? As I said, combo or monotherapy, you don't know. What's the treatment duration? It's an expensive treatment, and it might have a toxicity. So what is the adequate duration? Do we have any biomarker to predict response? It's very important. So now we have a kind of indication in breast cancer and other disease maybe, but do we have here a good biomarker for immunotherapy in non-small cell lung cancer? What about the adverse event? You know very well also that it's a new era. Adverse event for us it's something new, and we don't have a lot of background to talk about late long-term adverse event. How to monitor that, and what about resistance? You know very well that many of them will resist. So that's what I will talk about, and I will start, as I said, I will emphasize on Pembro. Dr. Hadi will go for the Nivo EP, and I will start with the combination of Pembro with pemetrexed platinum versus chemotherapy alone. It's the keynote 189, and where the primary outcome was the primary endpoint was the OS and PFS, and patient, as I said, compared the chemo immuno versus chemo alone, the same chemo backbone, and there is a maintenance in case of response. So for the first arm, it was chemo immuno maintenance. For the second arm, chemo alone. And all these patients were PDL tested, any expression were accepted, and all metastatic. And when I look to the to this curve, it's really impressive, because when you see the update, it has a ratio of 60:06, which means we reduced the death for about 40%. So imagine 40% reduction of deaths in non-small cell lung cancer, and the survival, the median survival is 22, for the combo 10. It's more than doubling. So I think results are impressive, and the follow-up, we have a median of 46 months, which again, it's excellent. So for those who are somehow old like myself, we know very well that lung cancer was really a very aggressive disease, and nowadays we are observing some survival, and we are talking about first line. So it's excellent. And when you look to the PDL1, you can see that almost all will get a benefit. The curve is almost, the difference between two curves is almost the same. So whatever the PDL1, this combination of Pembro, of immuno with chemotherapy is working. And also, we can say that there's a reduction of 38% for those who has liver metastasis. Why we are talking about liver mets? Because you know, usually it's more aggressive than others, and if you take the patient with liver metastasis, there's 38% reduction, which is really good, knowing that 60% almost had liver metastasis. And when we talk about TRAIN, it's almost 60% reduction of death. Yani, there is no need to tell you how important are these results, knowing also that 18% of this patient has brain metastasis from the beginning. And now another trial with another combination, the Pembro plus carbopaclitaxel or nab-paclitaxel versus placebo plus the same chemotherapy, also the same design almost. You can see that the primary endpoint also is PFS and ORR and OS. So all the parameters, we go directly to the source, to the OS, which is the most important. And here you can see that the 1 year overall survival is 65:48, which means there's almost there's 40%, 36% reduction in risk of death. Again, I repeat that we have never seen such result in such disease like lung cancer. And when you look to the 3-year follow-up results, we have also a 30% reduction. Still, it's maintained, as you can see. The difference here is really almost the same. So 30% and not 36, 30% reduction in death, which is really very interesting. And which means for the patient who will treat, 1 of 3 will stay alive for 3 years. And this is interesting to say that all subgroups will get benefit. It's amazing. All these subgroups are in favor of the combination. And the PFS, in my opinion, is no more important when you have the OS. Nevertheless, I've stated that the PFS also is in benefit in this case. And there is a meta-analysis taking all the pembro data with chemotherapy versus chemo alone, and it shows that there is a 37% decrease in the risk of death, and the median, the 1 year is 67 versus 47. The second year, the 2 years survival, 41.25. The 3 years is 24.13. It's almost doubling, which mean it's even improving. If you look to the relative difference in these, you see that really it's really impressive. Not doubling, a third, يعني tilt أعلى. So it's 37% decrease in the risk of this, which is also impressive. So here we talked about the combination because there's always this concern. Should we give the pembro alone or with chemotherapy? There has been some data showing that pembro in the high PD-L1 may not really be accurate. Personally, I had experienced some patients with a big bulk of the disease with pembrolizumab alone. I couldn't catch the disease. I couldn't stop the disease. So should we give combo or monotherapy? We don't have any comparison. We don't know. It's up to each doctor. You have to see the data, and we discuss. Why we are saying that? Because we have also data about the monotherapy, Keytruda pembrolizumab compared to the chemotherapy, any type of chemotherapy. And here we took the patient with a 50% and more PD-L1, and the major endpoint was the PFS primary, and the secondary was OS ORR. So the PFS was positive, and here the OS showed 80% versus 72%. So the study showed a positivity, and that's why it was approved. And in our practice, we used it a lot. Now, what matters for us is the overall survival update at 5 years. Again, guys, you have to look that at 5 years, where we have 16%, now we have 32% almost overall survival of patients at 5 years. So the 5-year survival is 32%. Should we consider that it's a cure? Because at 5 years, usually, probably we'll get a plateau, and usually we tell our patients that any disease, we take the 5 years as a cutoff. So we are saving with the monotherapy the third of our patients, approximately 32% of patients are alive with a very nice treatment, very well tolerated. So again, the overall survival analysis updated at 5 years showed that 32% of the patients are still alive compared to 16 for chemotherapy. So this is what pembro can do in monochemotherapy. And you can see here the PFS. Also, there is a big difference. The hazard ratio is 0.5, 50% reduction of relapse. Again, it's impressive. Now, we started the treatment, and it's my case. It's what should I do after 4 years? And we have a lot of patients like that. What to do later when we are giving treatment, we are getting complete response or partial response, what to do? In the keynote 189, a patient who completed the 35 cycles, which was the duration of pembro, had overall response rate 85%, with 4 complete response and 44 partial response and 8 stable disease. So the median OS was not reached for those patients who continued the treatment. So probably we have to continue if we rely on this study, as you can see, because the median of OS is not reached. When you look about the duration, also you can see, first of all, it's important to mention that even if we have PR initially, we still can have a complete remission later on, which is important also because we know that such way we can probably save the patient. And I didn't include it in my slides. Here, the keynote 4607, and here's the Keynote 24, where you can see also that many of patients continued the treatment, and 46% were alive without PD or any therapy for such patient. I didn't mention this slide here, but there is a lot of data in the literature talking about stopping the treatment after having a complete response or after having a high toxicity, a severe toxicity. So we know very well, for example, in renal cell carcinoma, patient who received immunotherapy with high toxicity did the same as those who in the study Ipi-Nivo, for example, did the same as, even better, the same who continued the treatment. And there has been reports, case reports, and some data suggesting that when there is a major toxicity, probably the benefit is continuous, and even if we stop the treatment, we can get response. So globally, the questions remain unresolved. There is different information from randomized controlled trial, and we need more data for the future. And the second line, we probably has to continue until progressive disease, since it's second line. Also, we don't know. For the first line, we don't know, but some trials like the Pembroke Keynote trials stopped at a certain number of cycles, 35, while others like Nivo, Atezo didn't. They didn't limit the duration. Any biomarker to predict response, it's important. When I have a biomarker, I will choose better my patients. I will deduce the economy burden. There is the PD-L1 till now is only approved, but unfortunately, it's not a robust biomarker. There is a lot of limitation. Now you can open the debate because there is a different detection antibodies. For every drug, there is a different antibody. So it's not easy. You have the DACO 28, 22, C3, Ventana, 2 SP142, 263. And this may contribute to the difference in observation in our practice and lead to a mass in our decision. Really, we don't know. We do sometimes in Lebanon what happens, and we can share the experience later. We do some tests, which is not the approved one in the defined trial. So you cannot. We are doing DACO, for example, for Atezo, while we should not probably, and we can open the debate with my colleagues later on. And also the tumor mutational burden is highly, the tumor microenvironment is highly heterogeneous. So maybe you can take a biopsy from a region where it's not represented, while in other organ and the other sites it might be present. So the heterogeneity of the cancer, the tissue, may lead to the mislead. The tumor mutational burden is also a biomarker. We had a lot of hope on this tumor, on this biomarker, but it was not really shown in all the study, only in the checkmate trials like the 227, where it was really interesting. So all what I want to say that the TMB may be interesting, but till now it's not really taken into consideration very let's say by guidelines. And remember that which is nice in the TMB, the blood and tissue TMB correlated significantly in a pool analysis, which make it easy for us. So probably we can go for the blood TMB if we decide to do it. And also here again, there's different platforms, different way to test this one. So maybe with time we will see that the TMB can be complementary to PD-L1. We had a lot of debate in the past. I don't know where it will lead us. Both are not really robust, but PD-L1 is the most adequate and is the most used in the guidelines. Now the first line algorithm, as you see, I will not stop here, but you look to the PD-L1 less than 1 up to 50, more than 50, and you decide based on the pathology also. What about the toxicity profile? So it's important. We had never been able to give chemotherapy or rarely for patients more than 6 or more than 1 year. The patients will be exhausted, very tired. What about the immunotherapy? We know very well that the checkpoint inhibitors will work on the inflammation. So this will create side effects. The pathophysiology is not well known, but for sure it's disruption of the immunohomeostasis. Maybe the toxicity might predict the efficacy, but it also will be associated with treatment discontinuation, which is not really bad in some cases. As I told you, cases of melanoma, of renal cell carcinoma, even of lung, those who had a severe toxicity went to almost complete remission. So it predicts efficacy, the toxicity, the immune-related adverse events, but it will lead to the discontinuation. And we know very well that it can affect many organs, one or many organs. And the core of this disease, this toxicity, the autoimmune reaction, and it might be asymptomatic up to severe or life-threatening. Personally, I have never seen a death or a PS4 with the immune-related adverse event, but I know that we had stopped in some patients and we could reinitiate the treatment in others. And important to know that it might accumulate over the course of therapy, so we can observe this toxicity not in the first years, in the first month, we can observe it in later year, second or more. And it's evident combo will increase the severity of immuno-related adverse event. And here, if we take the study of KINAT 024, and I took it because it's interesting here, we are comparing the immuno to the chemo, so there is no accumulation of toxicity. You can see that mainly the diarrhea, pyrexia, pruritus are more expressed in the immunotherapy. And when you look to these toxicity, it's really acceptable. So as you can see, in green, it's the chemotherapy. In blue, it's the immuno. So there is a big difference in the profile of toxicity in favor of the immunotherapy. And if we talk about the infusion reaction due to the immunotherapy, for sure it will be higher. And also the immuno adverse events are higher, like hypothyroidism, pneumonitis, all in blue, in favor of the, not in favor, due to the immunotherapy, and also this one in orange due to the immunotherapy. So we rarely observe toxicity, immuno-related adverse event due to the chemotherapy. It happens with the immunotherapy. And remember also, the time for occurrence might be different. It might be the first months, even up to many months or more than 1 year. So we have always to pay attention. And how to monitor the response. You know that we had a lot of criteria. We had WHO, RECIST 1, 1.1. On n'arrive pas à apprendre une méthode pour aller à la deuxième. Just we start learning about RECIST 1. We have RECIST 1.1. Now we have the immuno-related RECIST, etc. So a lot of evaluations method of criteria that will lead to a confusion for the radiologist and the clinician when they will use the immune checkpoint inhibitor. And unfortunately, we don't have a randomized controlled trial, and the radiologist will have also a problem assessing the tumor response because you know there is some cases of pseudo progression we'll talk about. So just to say, the latest published immunoresist criteria might be used for assessment, but I don't know how much it's used practically, and you can discuss this later. We don't know really how much it's used in our practice. And like, for example, the hyper progressive disease, here you can see initially with the chemotherapy, then after we started seeing these ground glass opacities. And when we started the treatment, it decreased. It shows that it's purely related to the treatment. Again, once stopping the treatment back, when reinitiating, it goes it can disappear. What's the message? What's the message? The message here is that you can reinduce the same treatment, and you can say that the toxicity might happen and might occur after reinitiating the treatment. Some meta-analysis about factors that might help for detecting this toxicity as liver metastasis side, LDH, and others. So it's only data, nothing more than that. Finally, is it a cure? Are we able to cure, since we have up to 30 to 40% survival, 30% at 5 years, or it's just an extension of survival, which will we be talking about the resistance? I will go quickly. We have many factors helping in the sensitivity for immunotherapy, many for the resistance, and I will not cite it, but it's important to see this because later on we will see that with time, now there is many treatment approaches aiming to inhibit the intrinsic immunosuppressive effect and to promote the immunogenic pathway. And this, as just the list, imagine there is a immunocombination, there is the re-challenge, there's the treatment beyond progression, there is the use of alternative immunocheckpoint, there is the immunotherapy with VEGF, with anti-VEGF, anti-angiogenic drugs, with radiotherapy, etc., etc. So the list is high, and we are using a lot of also factors that are playing on the resistance. And with that, I will go to the last slide, saying that now we know that the CTLA-4, PD-1, PD-L1 inhibitors are the most used nowadays as immunotherapy in non-small cell lung cancer. Pembro, in my opinion, is the only immunocheckpoint inhibitor that can be used alone in the treatment of PD-L1 positive non-small cell lung cancer. Combination for two immuno. And here I will send the, and it's the next presentation. So immuno can be used, or immunochemotherapy can be used in first line for those who has PD-L1 less than 50%. And despite the durable response, we will still have primary or has acquired resistance, or maybe initially from the beginning we will have a primary resistance. And we need more study to understand how to manage this patient. With that, I thank you very much, dear Chairman and moderator. Thank you.
Thank you, Dr. Fadi, for your lecture. And now we are going to our next speaker. We are about 12 minutes late. Our next speaker is Dr. Hadi Ghanem, who is hemato-oncologist in Lebanon. He will talk about the new era of dual immunotherapy in the first-line non-small cell lung cancer treatment. Please, Dr. Hadi, the floor is yours.
Thank you very much for the introduction. Thank you, Dr. Farhad, for inviting me to be part of this and for the organizers. So my part would be really to talk about the unmet needs and challenges in first-line management of advanced non-small cell lung cancer. I will be focusing mainly on the new era of dual immunotherapy. Dr. Farhad gave us a very nice general overview on the treatment and the incorporation of immunotherapy in the landscape of metastatic non-small cell lung cancer treatment. I will be focusing more, as Dr. Farhad very clearly introduced, the topic of using dual immunotherapy, which is a new one, relatively new one in the treatment of metastatic lung cancer. So just to add a few notes on what has been already shared by Dr. Farhad, and history is not that old, so I will comment on what Dr. Farhad said by saying that we don't have to be as old to know that lung cancer did not do well in the past. So this is very recent. As you know, this is data from 2014. Of the last 3 decades, many patients did not survive the 1 year with metastatic non-small cell lung cancer, especially if they had distant metastases. So their 5-year overall survival used to be in the single digit, as low as 4 or 5%. So As you know from this very nice diagram, the segmentation of lung cancer patients has really changed over time and in a very rapid way. So back in the days when I was in medical school, we still used to do the traditional view of lung cancer classification, which is dividing them in between non-small cell lung cancer and small cell lung cancer. And then that histologic breakdown put them into squamous, non-squamous, large cell adenocarcinoma, which is today completely unacceptable. As Dr. Gaspar said, and one of the questions came on this, do we need to test for all this and how can we test it? So today, it is not acceptable not to test for all these markers, and the molecular pathology is very important into deciding the best treatment for our patients. And last but not least, I know with a lot of limitations for the PD-L1 as a biomarker, it's a lousy biomarker. However, we use it today, and the expression of the PD-L1 is basically very important into our treatment guidelines. So today we're talking about patients who do have PD-L1 expression of 0 to 49%. I will show you in the next few slides. My talk will not focus on the more than 50% patients because those patients, as Dr. Farhat mentioned, are best treated with single agent immunotherapy. So what is the role of immunotherapy and how does this concept of immunotherapy, how did that emerge and why do we use it today? Again, I will not dwell on this, but we have the most compelling data on immunotherapy in lung cancer comes from the second line treatment. As you know, the first treatments that were done on advanced patients, mainly in second line. And I'll show you the pooled analysis from 2 phase 3 trials that were stopped early because of superior overall survival. So this was unheard of in the era of non-small cell lung cancer. Those 2 trials, the CheckMate 057 and CheckMate 017, were basically both of them stopped because of overall survival benefit in both studies for patients with metastatic non-small cell lung cancer, including patients with PD-L1 expressors and non-expressors. And I'll show you very quickly this data where nivolumab as immunotherapy drug was compared to docetaxel in the second line setting, and the pooled analysis from those 2 trials have shown a 5 times increase improvement in 5-year overall survival. And this is the longest phase 3 follow-up data that we have in any immunotherapy in metastatic non-small cell lung cancer, showing that at 5 years, we have 13.4% of the patients who are still alive as compared to 2.6% for patients who were treated with docetaxel as a second line agent. So this is very compelling. And as you see from this data, that this 5-year survival has been consistent across all subgroups, showing benefit regardless of the histology and regardless of the PD-L1 expression. So this is a very important data that has paved the way for immunotherapy in non-small cell lung cancer, and especially that the consistent safety profile over 5 years has been showing no new safety signals, and overall, most of the patients did not have severe or grade 3 or 4 toxicity that would have led to stopping their treatment. So based on this very important data in the second line treatment, researchers have advanced immunotherapy into the treatment of first-line non-small cell lung cancer, and that has paved the way for a new era of dual immunotherapy in first line. I will not talk about the pembrolizumab data as Dr. Farhat has very nicely shown the data. I will technically talk about this, the dual immunotherapy treatment. And as you know, despite the recent advances in the treatment, we know that many additional treatment options are still needed to offer durable responses for more patients. And the idea is to try to see if combining immunotherapy drugs together might lead to a better response and better survivals. So as you know, there is this combination of nivolumab plus ipilimumab that has been the most studied combination in cancer therapy. And that is because of a combination of 2 different mechanisms of actions. The first one being the ipilimumab, that is a CTLA4 receptor antagonist that has really a job to help activate and proliferate cytotoxic T cells. On the other hand, we know that nivolumab does, as a PD-1 receptor antagonist, does help the existing T cells to discover the tumor. By combining those 2 mechanisms of actions, our aim is to try to kill as many tumor cells as possible on one side, but also to develop memory T cells. Some of those T cells can be stimulated by ipilimumab and can become memory T cells on the long run. That is very important to maintain anti-tumor activity, but also to have a longer response to treatment, and sometimes for re-challenging the patients with the same drug and gain efficacy once again. As you know, we have data on 3 different types of cancer that have used this combination of ipilimumab plus nivolumab at variable dosing regimens, however, with long-term survival advantages. The first one, which is the longest follow-up that we have, is the one in metastatic melanoma. We have 5 years of follow-up today, and that 5 years have shown a very important overall survival of 52% for the combination. This has been replicated in advanced metastatic renal cell carcinoma and CheckMate 214 with more than 4 years of follow-up today, and we have a very important median overall survival advantage of dual immunotherapy versus sunitinib, especially in patients who have high-risk disease. And now we're going to talk also about metastatic non-small cell lung cancer with CheckMate 227 and CheckMate 9LA, and both of these we do have survival advantage that we're going to talk about next. So the 2 studies that I will go into details tonight are, on the one side, CheckMate 227 for patients with PD-L1 expression of more than 1%, and on the other side, so that's a chemotherapy-free regimen, and on the other side, we'll talk about the immunotherapy combination along with 2 cycles of chemotherapy for patients across PD-L1 expression, and that's CheckMate 9LA. So the first study is CheckMate 227. As you can see, CheckMate 227 was a phase 3 study that randomized metastatic non-small cell lung cancer patients who had PD-L1 expression of more than 1%. They didn't have to have a specific histology to receive on a 1-to-1 basis either Opdivo or nivolumab plus ipilimumab versus platinum doublet chemotherapy. And the primary endpoint of this study was overall survival. And as you can see here, the median follow-up was 43.1 months, and the longest median follow-up of any immunotherapy-based combination in a phase 3 trial. So these are the patient's characteristics. As you see, they were very well balanced as far as smoking status, histology, as well as PD-L1 expression. And here we're talking about patients who have strictly a PD-L1 that is positive, meaning more than 1%. Looking at the overall survival with the immunotherapy combination, you can see from this slide that patients who had a PD-L1 of more than 1% did have a better overall survival at 3 years with a combination of nivo plus ipilimumab, and that being a hazard ratio of 0.79, 17.1 months versus 14.9 months. More importantly, 33% of the patients were alive at 3 years versus 22%. So that's a very important overall survival advantage. And one of the most important drivers for this overall survival advantage is the fact that the patients who responded did have a durable response. And as you can see on this curve, these are ones who did have a response with the combination of EP plus nivo. You can see here that the median duration of response was 23.2 months for the EP nivo versus 6.7 months for the chemotherapy group. And that's a 3-year 38% versus 4%. So that duration of response of 23.2% at 3 years is very striking in CheckMate 227. Now, when you look at the responders at 6 months, you can see that 70% of them were alive at 3 years versus 39%. So again, once again, to mention that the patients who do respond to the combination of immunotherapy do actually have a better overall survival. Now, what about the toxicity profile for patients receiving dual immunotherapy? And we know that this has been a concern, especially with the older data of ipilimumab plus nivolumab in the melanoma setting. But we have to mention that this protocol used in non-small cell lung cancer patients did not use the same dosing of ipilimumab as the one in the historically melanoma patients. So you can see that the grade 3 and 4 related treatment-related adverse effects for patients with dual immunotherapy were actually much less than the previous reports of higher dose of ipilimumab, and there were no new safety signals identified for this combination. So we do have a 3-year landmark overall survival of 33%. We do have a median duration of response of 23.2%. So this is the longest median follow-up of any immunotherapy-based combination in a phase 3 trial. Now, switching gears to patients who did receive in the second phase 3 trial the treatment of dual immunotherapy with Opdivo and Yervoy, so Nivo plus ipilimumab. However, this time with 2 cycles of platinum doublet chemotherapy, and those were compared to chemotherapy as a first-line treatment for non-small cell lung cancer patients. Now, a few things that we need to mention, which are the rationale for doing this study. Of course, I've shown you how there is a synergistic effect of combining anti-CTLA-4 and anti-PD-1. So this we know from prior studies. And now we know at the starting of this study that Checkmate 227 have shown a durable response and overall survival benefit from this combination versus chemotherapy, but that was in patients who were PD-L1 positive. So adding a limited course of chemotherapy initially to the combination of immunotherapy, IPI plus nivolumab, could actually provide a rapid disease control while building on durable overall survival benefit observed with the immunotherapy combination. So if you remember the curve from Checkmate 227, you will notice that some patients are lost in the first 6 months. And this is basically what is tackled by using immunotherapy along with chemotherapy in Checkmate 9LA. So the randomization happened for all patients independently of the PD-L1 status. So patients were stratified, of course, by PD-L1 status, but even patients with less than 1% were included. And they're randomized on a 1-to-1 basis to receive either the platinum doublet chemotherapy, standard of care, versus the combination of immunotherapy, ipilimumab plus nivolumab. And here you can see the dosing, again, with the ipilimumab being at 1 milligram per kilo every 6 weeks, plus a platinum doublet chemotherapy of 2 cycles every 3 weeks. And those patients were then continued on nivolumab plus ipilimumab every 3 weeks for Nivo, every 6 weeks for Yervoy. And then they were maintained on treatment with Opdivo and Yervoy until disease progression, unacceptable toxicity, or up to 2 years if none of the previous had happened. The primary endpoint of this study was overall survival. And then we have to mention that those patients were evaluated across histology and across PD-L1 expression. So here you can see the baseline characteristics. You can see that around 40% of the patients were PD-L1 negative, around 60% being PD-L1 positive, and 22% of all the group, actually more than 50% positive. The other characteristics of the patients were well balanced in between the two groups, being 70% almost of non-squamous histology and 30% being squamous. And the majority of the patients, as you would expect, were actually current or former smokers. So in this very nice data that were presented at ASCO of last year, you can see that the count of chemotherapy plus dual immunotherapy did actually improve the 1-year overall survival in the intent to treat population to 63% for the combination versus 47% for chemotherapy, with the median overall survival of 15.6 versus 10.9 months, hazard ratio of 0.66, highly significant p-value. So you can see here that this overall survival benefit did actually was actually seen across all subgroup of patients, including patients who are PD-L1 negative. So this is the curve of OS for patients who are PD-L1 less than 1%. And you can see that the median overall survival was 16.9 months versus 9.8, favoring the combination of immunotherapy plus chemotherapy. 1-year OS 63% versus 45%. So this slide is actually will show you this same curve, one divided by PD-L1 subgroups, and you can see that the curves are behaving fairly similarly as far as the differences versus chemotherapy. Of course, as you'd expected, patients with PD-L1 of more than 50% were the better responders, with a median overall survival of 18 months, hazard ratio still being very compellingly positive. So when you look at the differences across histology, again, overall survival benefit was seen across histology, whether these were patients with non-squamous versus squamous. Again, median overall survival was very positive, hazard ratios 0.62, 0.69. Now, the overall survival benefit across all subgroups was also seen. You can see here that most of the subgroups excuse me, did actually benefit from the combination of immunotherapy plus chemo, dual immunotherapy, maybe except those patients who were older than 75 years and those patients who were never smokers. And as we know, these are the two typical population of patients who seem to benefit less from immunotherapy in general. Now, the adverse reactions, as you would expect, could be a little bit worse when you're combining immunotherapy plus chemotherapy. However, the fact that chemotherapy was used only for 2 cycles did not increase those chemotherapy-related side effects too much. And you can see here that the treatment-related adverse events versus therapy alone were actually higher with chemotherapy group because the fact that chemotherapy in the combination arm was only used for the first 2 cycles. So as a conclusion to Checkmate 9LA, you can see that the overall survival did actually improve. The 1-year landmark overall survival was 63% versus 47% with chemo at a minimum follow-up of 1 year. You can see here the dosing regimens for the Checkmate 227 and Checkmate 9LA. You can see here that there are some differences in the dosing. Being Checkmate 227, the nivolumab dose is 3 milligram per kilo every 3 weeks. For ipilimumab, it's 1 milligram per kilo every 6 weeks. This is slightly different from Checkmate 9LA, where the nivolumab was dosed at 360 milligrams, and that's every 3 weeks, so that's a flat dose. And again, with the ipilimumab being 1 milligram per kilo every 6 weeks. You can see here that the 360 milligram dose was used to match the chemotherapy schedule, which is usually given every 3 weeks, depending on the regimen used, but just to make it easier on the patients. So as a summary, Checkmate 227 was a proof of concept that immunotherapy alone, a dual immunotherapy regimen, is feasible for patients who do express PD-L1 of more than 1%, regardless of the histology. Checkmate 227 has shown an overall survival benefit, and 33% of the patients are still alive at 3 years. Even for patients who are PD-L1 more than 1%, 70% of the responders at 6 months were still alive 3 years. So it's important to identify those responders early on, because those are the ones who do actually respond long-term. This is comparable to Checkmate 9LA. However, here we're talking about all patient subgroups, including the patients who had less than 1% PD-L1 expression. We have shown also the data earlier than what we've seen for 227. However, the 1-year data landmark has shown overall survival benefit across histology, across PD-L1 expression level. So this is another opportunity for patients to benefit from dual immunotherapy with shorter chemotherapy regimen. So with this, I think I'll end my presentation and we'll be happy to take questions and open to the panelists. Thank you very much.
Thank you, Dr. Hadi, for the excellent lecture. We'll take the questions after the lecture of our next speaker in this session, that we are going to have every activity about the young oncologist. That's why we're approaching the young oncologists in our area, that we have more than 700 young oncologists below the age of 40. So I'm welcoming Dr. Yola Makdouki. She is hemato-oncologist at Makassar General Hospital, and will talk about the Young Oncologist Corner Lung Cancer New Approval. But I would like to announce, and please save the date, that on June 8th of June, we have our next module, which will be about breast cancer. Thank you. Please, Dr. Yola.
Thank you for giving me the opportunity to participate to this very interesting course. And I will be talking about the new approvals in non-small cell lung cancer. As we were seeing from the beginning of the course, that the lung cancer is becoming more and more personalized, and the new approvals show this also. So I will talk in detail about the latest 3 approvals: amivantamab, lorlatinib, and cemiplimab, but also about tepotinib and osimertinib.
to end with conclusions and new horizons. For the treatment paradigm in 2020, my colleagues already talked about the interest of doing molecular testing, immunohistochemistry for molecular alterations or for PD-L1 in front of every case of metastatic or locally advanced lung cancer that we see in practice. And the treatment schema nowadays is based on these findings. The new approvals in 2021 also are about to target these new or old biomarkers. So the first one is amivantamab, which got the FDA accelerated approval on May 2021. It's a bispecific antibody that induced an immune reaction. Sorry, because I'm not seeing my slides. Okay, it targets both EGFR and MET receptors. The FDA approval was given to adult patients with locally advanced or metastatic non-small cell lung cancer with EGFR exon 20 insertion mutations as detected by an FDA approved test upon progression or after platinum-based chemotherapy. This approval was given according to Chrysalis studies, which is an open label multicenter first in a human study to evaluate safety and pharmacokinetics and preliminary efficacy of amivantamab as monotherapy or in combination with lazertinib, which is also a TKI, a potent TKI, targeting both T790M and activating EGFR mutations. So I will talk a little bit about EGFR mutations. We all know that EGFR mutations are various. We know particularly the activating mutations sensitive to EGFR TKI first, second, and third generation, especially in exon 19 and deletions of exon 19 and exon 21, and the T790M in exon 20. Exon 20 mutations actually are a little bit embarrassing because they are heterogeneous, but also they confer a resistance to first generation and second generation to EGFR TKI. And till now, the standard of care is chemotherapy, particularly pemetrexed in this case. Many EGFR TKI targeting these exon 20 insertion mutations have been developed. There is poziotinib, mobocertinib, and the one we are talking about, amivantamab. So amivantamab, as I said, it's a bispecific antibody targeting MET mutations, but also EGFR mutations. And in the population, in the specific population of post-platinum therapy, which were 81 patients with EGFR exon 20 insertion mutation, the response rate was 40%, duration of response 11 months, PFS 8 months, and overall survival almost 2 years. The response rate in patients with brain metastasis was 39%, and the toxicity profile was good with only 16% of grade 3 and 4 side effects. So amivantamab, now we don't find it in the NCCN guidelines because the FDA approval was in May, but the latest version of NCCN guidelines was in April 2021. But for the moment, it's the most efficient and the less toxic EGFR anti-targeting. The antibody targeting EGFR that shows efficacy in exon 20 insertion mutations. I move to the other one. The other approval has been granted to lorlatinib on March 2021 in metastatic non-small cell lung cancer with ALK regimen detected also by a FDA-approved companion test. So as we know, ALK rearrangements account for almost 4% of all non-small cell lung cancer, independent from the ethnicity, while EGFR are more frequent in Asian. And we are using nowadays immunohistochemistry, which has a lower code than FISH test to find ALK rearrangements. And the second generation ALK inhibitors showed a better efficacy than crizotinib in first line. And they have already approvals in first-line treatment, like ceritinib, which showed already a PFS of 16 months. Bricatinib, the PFS was not reached. Alectinib, the PFS was 34 months. And the interest of lorlatinib, it's also a potent ALK inhibitor showing activity, as I will show you the curves in first-line non-small cell lung cancer. But the particularity of lorlatinib, that the only one that can act on the most frequent resistance mutation to ALK inhibitors, the G1202R. For the moment, we are not searching for this mutation upon progression. We move from one generation to other generation of ALK inhibitors. We don't search for this mutation like in EGFR when we search for T790M when we have progression on a first or second generation EGFR inhibitor. But at the importance of lorlatinib, that is the most potent one on this resistance mutation. So the FDA approval was given upon this controlled randomized trial comparing lorlatinib to crizotinib, lorlatinib 100 milligram once daily. And the major efficacy outcome was progression-free survival. And as we see here, the progression-free survival was significantly improved in lorlatinib arm, with a median progression-free survival not reached in lorlatinib arm versus 9 months with the crizotinib, as all the previous study showed. The survival without CNS progression was also significantly improved in lorlatinib, and the intracranial response was 82% in the lorlatinib arm. The toxicity profile also is better with lorlatinib. We also see the fatigue, diarrhea, nausea, elevation of transaminase that we see in all ALK inhibitors, but it's the grade 3 and 4 are less than the other ALK inhibitors. We have a particular toxicity profile with weight gain and mood effects, also hypercholesterolemia and hypertriglyceridemia. The third approval is semiplimab, Libtayo, that had approval on Feb 22, 2021. In first-line treatment of patients with metastatic or locally advanced non-small cell lung cancer, not candidates for surgical resection or combination of chemoradiation. The patients had high PD-L1 expression, which was measured with TPS more than 50%, and no EGFR or ALK or ROS1 aberrations. This approval was given according to the Empower Lung study, which compared semiplimab 350 milligram IV Q3 weeks to chemotherapy of investigator choice. So semiplimab was given until progression. The schema, as you see, is very similar to the one comparing pembrolizumab to chemotherapy in first line, but the only difference is that we had the option to add 4 cycles of semiplimab with chemotherapy upon progression. The main outcome was median PFS, which was significantly improved in the semiplimab arm with 8 months versus 5 months with chemotherapy, and the median overall survival was not reached versus 14 months in chemotherapy arm. And when the results were presented, the authors showed us that overall survival as well as PFS and response rate were improved according to TPS. So when we had a higher PD-L1 expression, we had better overall survival, better PFS, and better response rate. The fourth approval, now I will be more rapid because I think I don't have time. I took my 10 minutes maybe. So tepotinib got approved on February 2021 in adult patients with metastatic non-small cell lung cancer harboring MET exon 14 skipping mutations. And the approval was given according to VISION trial, which was a multicenter non-randomized open label study. And the dose was 450 milligram PO under disease progression or toxicity. The response rate was the main efficacy outcome, and it was 46% in the combined biopsy cohort. All were partial response. We didn't see any complete response, and the median duration of response was 11 months. The last approval that I will talk about was on December 2020 to osimertinib in the adjuvant setting in patients with non-small cell lung cancer with EGFR exon 19 or exon 21L858R mutation that we all know, the activating mutations. And the dose was 80 milligram once daily until progression or toxicity or up to 3 years. We all know that there was no benefit for other EGFR TKI previously in the adjuvant setting, and in the first one approved according to the study ADAURA trial, which compared osimertinib to placebo, as I said, until progression, toxicity, or up to 3 years. And the main efficacy outcome was disease-free survival, which was significantly improved in the osimertinib arm. The median disease-free survival was not reached versus 19 months in the placebo arm. We showed that we had approval for amivantamab in locally advanced or metastatic non-small cell cancer with EGFR exon 20 insertion mutations, norlatinib in first-line treatment of metastatic non-small cell lung cancer with ALK rearrangements, semiplimab as immune therapy in first-line treatment non-small cell lung cancer with high PD-L1 expression more than 50% in metastatic or in locally advanced, not candidates for surgery or chemoradiation therapy, tepotinib in metastatic non-small cell lung cancer with MET exon 14 skip exon mutations, and finally osimertinib in adjuvant therapy for patients with EGFR mutations. And we are surely having new approvals, new biomarkers, and more personalized medicine in the future. Thank you.
Thank you, Yola, for the excellent update, and you are welcome always as all our junior oncologists. So now we have just 10 minutes with the panelists to take the floor again and to discuss any issue and answer the questions that we have from the participants. Please, panelists, Dr. Amani, Dr. Youssef.
So I'll take few questions, some of the questions asked by the attendees. So if you are a policymaker, which protocol you will adopt, chemo plus pembro or nivo ipi? So I think Dr. Farhat and Dr. Ghanem.
Yeah.
If you would like to answer, yeah.
So it's a hard question. But I believe that in each country, they have to do their proper cost analysis. So while the pembro monotherapy is interesting, it's only one drug. Pembro chemotherapy, the price might be affordable since the chemotherapy is not expensive. You can argue that ipi-nivo, it's a treatment where you give a specific number of ipi and you continue nivo. So all are good. What I think as a policymaker, I will try to deal with the with the prices. That's the only difference. I can't see any real difference between all the immunotherapy because every protocol has his criteria for inclusion and has his subgroup of patient which might benefit more. So as policymaker, it should be a cost analysis that might help.
Okay, so here is another question.
If I may add something.
Yes, sorry.
I agree with Dr. Farhad on this, and I think as a policymaker, it's very hard to make a choice, but also medically, we don't know what to use. I mean, today we don't have any comparative trial between dual immunotherapy plus chemo, plus or minus chemotherapy versus chemo plus Keytruda or pembrolizumab. So in the absence of medical comparison, it's even harder for the policymakers to make their choices. And it would be very, very hard. So what, as a rule of thumb, I think we just have to say that both regimens are available. We have to gain experience using both of them. We have to see what's relevant to each country, as Dr. Farhad said, and to try to fit our patients within a specific protocol. But otherwise, I think it will be very hard as clinicians and as policymakers to choose amongst those regimens because there is no right or wrong answer. It depends on the patients and the situation of the country.
Juste une petite remarque, Dr. Laila, c'est que je pense que l'évolutivité et l'agressivité de la maladie aussi jouent un rôle comme... On peut le considérer comme un critère pour des patients qui sont très symptomatiques, avec une maladie assez agressive et qui est rapidement évolutive. On peut faire plutôt la combinaison immunochimio et pour des maladies plutôt indolentes, lentement évolutives, une monothérapie, donc du pembro seul aussi. C'est vrai qu'il n'y a pas de comparaison face-to-face entre les deux options thérapeutiques, mais un critère clinique tel que l'évolutivité de la maladie peut être aussi important à considérer aussi.
Oui, bien sûr.
Just a comment, still, since again, it's an educational course, it's a personal opinion since we don't have any data. So, dear Dr. Amina, you confirm that it's an impression, it's a feeling, it's not an evidence-based. It's true that personally also, I love using chemotherapy immuno, but it's an impression. We don't have any confirmation that it's better than a combo immuno. Do you agree on that, Dr. Amina?
Oui, oui.
Okay.
So I have a question. Do you think that the entity of oligometastatic disease does exist in the lung cancer? For example, if we have a resectable lung disease with a single brain metastasis or with a supraclavicular lymph node, let's say, would you consider it as a stage 4 and you go for systemic treatment, or would you still go for an aggressive approach with surgical or radiation therapy?
Maybe we can leave this question to the pneumologist, pulmonologist, and the thoracic surgeon. I think we have a lot of common experience also. So, Dr. Pierre, Dr. Gaspar, do you want to comment?
So when we talk about resection of lung surgery, and Pierre will confirm this, first we have to, first we see if the tumor is resectable, then we have to see if the patient is a candidate for resection, if the lung function will permit it. For the oligometastatic disease, I think it's a case-by-case decision and discussion, because we have to do a lung surgery, and then it depends where the metastasis is, a brain surgery or liver or whatever. I think there may be some benefit in some patients, but I think it's a multidisciplinary discussion and a case-by-case.
Okay, Dr. Youssef, do you have a comment?
Just want to say that in case of a single or 2 lesions in the brain, it is proven that a brain metastasectomy and thoracic surgery, inclusive lobectomy, it is still well indicated. And I think all of us with our experience, we have these patients who are still alive multiple years after brain metastasectomy and lobectomy. I mean only lobectomies or bilobectomies. I would like to exclude pneumonectomies in this case. For brain, it is well proven, it's well acceptable worldwide. For other oligometastases, I think also a one single lesion in the liver or in the lung without lymph nodes, it is also to discuss. The problem it will be if you have a lung tumor with multi-station lymph nodes and a single metastasis outside the lung. I think it will be very difficult, and perhaps there is a role for neoadjuvant chemotherapy and then to discuss the situation. Perhaps I have done sometimes in my life until now, but we have to discuss it case by case. But for the brain, definitely it is a chance for the patient.
Any other comment, Dr. Hadi?
Yes, if I may add one comment, because you specifically mentioned the possibility of having a supraclavicular lymph node, Layal.
Yes.
So I think this is a very important question, because if you look at the classification and the staging of lung cancer, having a supraclavicular lymph node will not be considered as metastatic, it will still be a stage 3C. So technically those patients might still be amenable to definitive treatment, especially now that we have the possibility of giving them durvalumab post-chemoradiation. We recently reviewed this subject as we had a very unusual presentation of a patient who had a contralateral isolated supraclavicular lymph node metastasis, despite the fact that she did not have an ipsilateral supraclavicular lymph node. And we were debating whether we would consider this patient to be a metastatic stage 4 or a stage 3C, because as stage 4, she would receive immunotherapy plus chemo in first line, or if you would consider her as stage 3C, we would go for maybe induction chemotherapy, but also chemoradiation, definitive treatment. So it's a matter of debate, but if you stick to the classification, a supraclavicular lymph node, whether it's ipsilateral, contralateral, or dual ipsi and contralateral, will still make the patient a stage 3C disease. So technically amenable to chemoradiation followed by maintenance or consolidation durvalumab.
Layal, can I?
Okay. Sure.
I would like to ask Dr. Amina, Professor Amina, the experience in l'expérience dans le pays de Maghreb, en spécifique Tunis, parce que comme Dr. Pierre.
Est-ce que vous m'entendez?
Oui.
Oui. Alors, malheureusement, en Tunisie, on n'a aucune AMM d'immunothérapie, que ce soit en première ligne ou en deuxième ligne. Il y a un dépôt de dossier pour la deuxième ligne, pour la TESO, et la première ligne pour les CPC métastatiques, mais aucune AMM déposée en première ligne. Donc, on est vraiment... On est très loin de la, entre guillemets, de la réalité. On dirait qu'on fait une médecine parallèle, puisqu'on reste, dans notre chimiothérapie classique jusqu'à avoir l'accès à ces traitements, malheureusement.
Dr. Amina, I wanted to ask about the experience of oligometastatic disease. So, yeah, that's my question. So, you answered for the another question, but specifically, what do you do? Are you we somehow are a little aggressive when it comes to oligometastatic, and I invite all attendees, all colleagues, to know that really we try to be aggressive nowadays. We are curing patient or prolonging well survival when there is oligometastatic disease, which means 1 or 2 metastases in a specific organ and sometimes in 2 different organs. So what's your experience in the region, Dr. Amina?
Oui, oui. Alors, chez nous, puisque je suis à l'Institut Salhazaïs, qui est un centre anticancéreux, malheureusement, on a une sorte de billet de sélection, puisque pratiquement, donc 90% des cas, on a des patients plutôt polymétastatiques. C'est vrai que les rares oligométastatiques, que ce soit au niveau du cerveau ou au niveau de l'os ou au niveau des surrénales, on va, puisqu'on n'a pas accès ni aux thérapies ciblées ni à l'immunothérapie, donc ça va être, on va être classique et on va démarrer par un doublé à base de platine et faire un traitement local, loco-régional entre guillemets, en cas de bonne réponse, soit notamment surtout à base de radiothérapie. Même la radiofréquence, l'accès à la radiofréquence dans le secteur public est assez limité.
So there is a question from the attendee. Is there any difference between PDL expression, MSI, and tumor mutational burden when deciding immunotherapy?
PDL1, MSI, and tumor mutational burden. I will start, if you may allow, Dr. Hadi and Dr. Fadi Karak, if he's here. Yes, the only one approved is the PDL1. TMB, I will keep this answer to Dr. Hadi Ghanem since it's related to the NIVO-IPI trial, but for outside NIVO-IPI, the PDL1 is the only marker approved till now to be used. It's not fully robust, but it's the only one, while TMB is approved in some indications, is used in some indication. First, second, always pay attention which PDL1 is used, which test, with which drugs. So there's some misconfusion in this testing, because we have 4 different tests for 4 different drugs. What about TMB, Dr. Hadi Ghanem?
So this is a very important question, and I think it can really get very confusing with the wealth of data that's coming up with all the different tumor types, not just in lung cancer. But I think it's very important because it's our job as well to educate our pathologists about the testing that we do, and not educate in the sense of they don't know, but to tell them, give them hints about the drug that we're thinking about using. For example, if I'm contemplating the use of like atezolizumab, then yes, I might be compelled to use TMB. But if we're thinking about using drugs like pembrolizumab, or even combinations of nivolumab and ipilimumab, like I've shown you in the 227 and Checkmate 9LA, I think the only biomarker that we need to use is the PDL1. Now, there is really no role for MSI in lung cancer patients, metastatic lung cancer patients. MSI is really used across the boards as an agnostic tumor marker or marker for or biomarker, meaning that if you have MSI high tumor in any type of tumor, whether it's GI, whether it's kidney, whether it's sarcoma, anything that has an MSI high signature, those patients can be treated with pembrolizumab. So that was the first, if you remember, agnostic approval for any drug in the world based on a biomarker independent from the histology. So to keep it simple, for patients who have lung cancer, metastatic lung cancer, in which we're contemplating to use either pembrolizumab, a single agent, or combination of EP plus Nivo, the only biomarker that we tend to use and that we have available and reproducible in pathology labs outside of research studies, of course, is PDL1.
So if Dr. Yeah, sorry.
تفضلي ليال.
لا كنت بدي أختم بس تفضل.
It's okay, you can خلاص معش سبقنا الوقت.
Okay.
Sorry, but one question for my oncologist colleague. As Dr. Amina said, it is really difficult in Tunis to give the patient this very expensive medications. My question for my Lebanese colleagues, our country is now in a very similar, very difficult situation. How it is really possible to give our patients now the chance for this kind of very expensive treatment?
Do you go
I'd like to
I
comment.
think 2 years ago, nobody of us could imagine to ask this question, I think, for Lebanon in comparison with Cyprus, for example. 2 years ago, it was the normal way to give them all this.
Pierre, the question, and I missed the question. So you are saying that in Lebanon, with the crisis, the economical crisis, what will be our future in using these drugs? That's the question?
Yeah. How will influence?
يعني كده شو هو التأثير علينا؟
أنا سؤالي إنه نحن قبل سنتين ما كانت ممكن نتصور أي دواء يكون موجود بالعالم إلا الأونكولوج بلبنان يقدروا يستعملوه لمرضاهم. اليوم هلا بكل هودي الأدوية اللي عم نحكي عنهم، وين صار هلا لبنان بهودي الأدوية؟
مع الدعم أحسن.
أوكي.
مع الدعم وضعنا أحسن.
عم تدعمهم وزارة الصحة؟ عم تدعم هول الأدوية؟ عم تقدر تأمنوا وزارة الصحة؟
at least البيشنت صار في إذا حدا قرابته برا في يبعث له أقل مصاري يقدر يشتريهم.
بس till now it is covered by the Ministry of Health, and in most of the indications, not all of the indications, most of them we have it. Yeah.
الجيش عنده عم يقدر يأمن هذا.
we have all the treatments till now, and in the army we have all the treatments. Yes.
Let me try to answer Dr. Pierre. First, we are in the transition period. We do not know what will be the future, the near future. If there will be a support for these drugs, we can probably continue. But let's say that we had some abuse of use of these drugs. That's sure. We tried for many years to talk with the Ministry of Health, so you could not afford such drugs for the future because the impact is very high. What you can do first is to choose better your patient. Second, you have to learn, it's mainly for also for our young oncologist colleague, try to use compassionate treatment. We have a lot of options to use the treatment in compassionate use. Drug is approved but not yet on the market. Three, you can try to include your patient in clinical trials, and also it might help. It will not replace the insurance, but it might help. But no doubt that we have to change our policy because we had a lot of abuse by using the imaging, the labs, and the drugs. Maybe you have to conclude.
Yes. First, as a member of the Young Oncologist Group, I would like to thank Dr. Farhat really for involving us this year in this very interesting course, and we hope for more collaboration. Thank you all for the speakers, and thank you for the organizers. And I think we'll have to conclude now. Dr. Farhat, do you have any last word to say?
Yes. Thank you, all the attendees. Thank you very much for the speakers and the panelists for this nice interaction. Thank for young oncologists. Layal, your group will be part in each session. We have a young oncology corner, so you will be involved in each module, each session. And the next time we need more your vision for the future. Now for today, for example, we're talking about the drugs. It concerns you more than us, the old generation. So the young generation should be prepared to answer such questions. The speakers, it was really excellent presentations today. Thank you very much. It was really basic with promotion. It's okay. Dr. Amina, thank you for your participation. Merci beaucoup, Dr. Amina. the Tunis. And thank you. We'll see you in 6 June with the breast session, next breast session in
8th June.
8 June, sorry, أنا دايما بلخبط. 8 June. We will send you the information the soonest. And if you have any suggestion, please send it to us. And finally, thank you a lot, SciencePRO, the organizer, for the excellent work. And see you the 8th of June. Bye-bye.
Thank you.
Ciao.
Thank you. Thank you so much.
Bye.